Good morning, everyone. My name is Shahrouh Sharif. I'm working at Community Systems Foundation. We're one of the developers, the technical developers for the EQUIST tool. I've previously worked at UNICEF in their health systems strengthening unit in the health section, where we've worked on the development of this tool and worked on the methodology of this tool, and I've been involved in the launch of the version of this tool and worked on the second version leading up to its release and shortly after its release. So today I'm just going to go over how EQUIST was applied in Ghana. And this is, I think, a unique example of how EQUIST was applied in country, mainly because of the data that was used. This was the first real application of routine data, so looking at their HMIS, their Health Management Information Systems, called their DHIS2. And with this type of data, we delved into district level analysis and got district level results in terms of conducting a Baldneck analysis, identifying where the poorest populations or the worst off populations or most vulnerable populations were, and then working up to identifying what their causes of mortality, morbidity are, which health interventions would need to be implemented to address these issues, and then working on the Baldneck analysis to determine ultimately what sort of outputs were needed in terms of, and what sort of impact these strategies had in terms of reducing mortality and morbidity, as well as what costs were involved through the EQUIST tool. So there were 3 workshops held. There's 2 pictures shown here. The first on the left-hand side is the capacity building workshop. So this is where we ultimately came in as UNICEF and provided training in terms of building capacity at the national level, just to have further support provided and more further trainings or refresher trainings provided to participants at the subnational levels. And the workshop, in the image you can see on the right is from their immunization workshop. There was also additionally a nutrition workshop with nutrition focal points using EQUIST for health policy planning decision making, as well as developing an investment case. So moving on to more of the introduction of how EQUIST was requested to be implemented in country. So Ghana has had very good coverage in terms of immunization. What the data has been showing is that at national levels and provincially, they've had high coverage levels comparatively to the region. So they've been very strong in their immunization program. In fact, they've had 99% DPT3 dose coverage in 2016, with 153 out of 215 districts achieving DPT3 coverage of 90% and above. And this is from their joint reporting form that they had in 2016. But despite these improvements in 2017 and 2018, there were assessments conducted and showed that there were widening inequities in human resources and coverage for key interventions. And as we go through this presentation, we'll see that in certain regions you have this higher levels of disparity compared to other regions, either based on wealth or based on facilities and infrastructure and access to healthcare. These workshops were put in place with the support of Gavi, which is the Global Alliance on Vaccinations, and they wanted to see how EQUIST could help in improving coverage of these health interventions, especially among the worst off, and to address inequity with the lens of immunization. And so at this time, Ghana was not able to achieve what's known as the GVAP target, the Global Vaccine Action Plan target, where 90% of their districts would need to achieve for example, DPT-3 coverage of 80% or above. So it would be necessary to look at this lower level data, despite the regional level data showing you, or the provincial level data showing you that you are achieving this the GFAP targets in terms of area. So this is important to look at to address inequities. So in terms of the objectives of the workshops, the objectives were to identify what these equity gaps in health and nutrition were, and which high impact interventions with a strong focus on immunization and vitamin A supplementation would provide a strong impact. There was a need to develop a national capacity to reinforce and to conduct an equity analysis for maternal and child health. The EQUIST platform, they worked to link, they worked with the Ghana Health Service to link their DHIS2, which is called in the country DIMS, data set to enable for continuous monitoring of program performance. So with, in this situation, we worked with the Ghana Health Service and the individuals in charge of DHIS2 and set them up as workspace administrators at the back end of EQUIST, so that they can be involved in the process, on the data entry process, as well as on the data analysis, data validation, and putting in the new maps and the district level maps and features, and even health facilities, as you'll see soon. So they requested for a detailed report that identifies unimmunized children where there are within the country and factors driving access to immunization for these children. They looked to try and attain specific costed strategies and targeted actions to reach these unimmunized children for immunization services and vitamin A supplementation. And then finally, what they were looking for is to develop investment cases for specific interventions to mobilize resources and bridge the equity gap based on the analysis report. And they even had developed microplans as well at the regional level to identify which districts they would really need to sort of address through these plans. So what was captured on EQUIST and through this linkage with DHIS2 and the PPME team of the Ghana Health Service was 215 districts in 2018 and 10 different regions. So this was the, I think, most dense and highest application in terms of number of districts on EQUIST at that time. And this was sort of also a test on EQUIST to see if it can handle this level of data. So we were able to capture this data. One interesting new feature that we had were the health facilities. So what we were provided from PPME as well was the number of health facilities throughout Ghana, and this is something I've shown in previous presentations, but it's just fascinating to see the density of health facilities and how that can impact under 5 mortality, for example, where you see the 2 most populous cities, Greater Accra, Accra as well as Kumasi, having the highest, most populous cities and having the highest density of health facilities and having lower mortality rates when you look at, when you compare it to the northern regions, which have higher rates of mortality, under 5 mortality, as well as less dense facilities and more remote populations who may have trouble accessing these facilities. So it's an important way to conduct your analysis and an important piece of information. So there were 3 workshops held in Ghana, as I mentioned. The first was a capacity building workshop the first week of October in 2018. So this was pretty much exactly 1 year ago. And there was a workshop to train at the national level a few participants on EQUIST, and who were involved were UNICEF, the UNICEF Ghana Country Office, the Ministry of Health, the Ghana Health Service, and the University of Ghana. There were several students from New York University as well who joined. They have a New York University campus in Ghana, and they were interested in this this sort of analysis and in learning EQUIST, so they were they were involved in the facilitating and training those that were at New York University and had received that training. And so the participants trained at the workshop included the Ministry of Health, Ghana Health Services, nutrition and immunization experts who would help facilitate at further workshops. So in the following workshops that took place just after this initial workshop, some of these core group of nutrition experts would go and provide facilitation during the nutrition workshop, and the immunization experts would go and provide facilitating at the immunization workshop. So the nutrition investment planning workshop it followed just after. It took place on October 15th to October 19th, and this was to train nutrition experts and Ministry of Health participants representing all 10 regions on EQUIST and generate scenarios to develop a nutrition on investment case. From CSF, we also had someone from the development team on EQUIST who was working, I think, at this time on setting up the DHIS2 data for nutrition. So he was involved in country in the workshop. And then finally, there was an immunization investment planning workshop at the end of October, and this was similarly to nutrition to train immunization experts from the Ministry of Health and Ghana Health Services coming from all 10 regions of Ghana. So we had all these focal points who would provide their input and work as groups in terms of specific topics of immunization to identify where the problem areas were in terms of bottlenecks and which populations were more deprived or more vulnerable in this case. What was interesting was John Snow, Inc. also joined, and they had done an analysis at the urban levels, at district levels, on immunization, and they contributed to the analysis and wanted to see how this could fit into EQUIST as well. Some focal points as well from the regional office, from the Western Central African Regional Office of UNICEF had also joined and provided a training on the One Health tool, specifically how the outputs from EQUIST in terms of impact could feed into the One Health tool to provide a complete costing analysis, a whole budgeting costing analysis, which they would further take on and provide further costing information to develop this analysis. So I'll just fly through this very quickly. The attendees of the capacity building workshop. So there are 10 Ghana country office participants at various levels of familiarity with EQUIST. And then there was one participant from CSF, from the Delhi lab, to provide training on the back end of EQUIST, specifically to the Ghana Health Service focal points who worked on the analysis and who worked on the DHIS2 data. So there was 3 Ghana Health Service, PPM-ED, these are the ones who work on DHIS2, and there were MOH participants who were familiar with DHIS2 and had some experience with EQUIST. And 3 of these Ghana Health Service and Ministry of Health focal points actually traveled to Delhi to receive training at the Delhi labs on EQUIST as CSF manages the tool itself and can give trainings on how to set up a workspace administrator account for these specific key people, and to train them further how to work on inputting the data and updating the data and working on the visuals. There were approximately 30 Ministry of Health participants with different levels of experience with EQUIST, and all participants were given background reading prior to the initiation of the workshop so that they were a bit familiar with EQUIST. There was, from this group, there was facilitation given from the core group of facilitators from the capacity building workshop. So in terms of the nutrition investment planning workshop, this was held in Kumasi in Ashanti region, which is the second most populous city in Ghana. In terms of the preparation for the workshop, there was initial discussion with UNICEF Nutrition Focal Points, which is in Accra, the UNICEF country office. So we had an initial discussion with the nutrition focal points to determine that focal areas for an investment case were determined to be vitamin A supplementation, early initiation of breastfeeding, exclusive breastfeeding, and therapeutic feeding for SAM treatment, so severe acute malnutrition. And the latest data sources were looked at and explored to update EQUIST with the latest nationally available and globally validated data as well. And thereafter, then invitations were sent to the Ministry of Health and Ghana Health Service nutritional focal points, and in order to obtain participation in this workshop from every single region in Ghana, so we get the full picture of where issues lie within Ghana, and where the worst off were, and how to address these nutritional nutrition causes of morbidity, mortality. So further preparation, what we looked at was the DHIS2 data, their DIMS data. This was provided by Ghana Health Service for relevant nutrition indicators, and Ghana Country Office provided the Ghana Micronutrient Survey for 2017, which you can see here, and the Maternal Health Survey, which all provided some additional nutrition indicators needed for the focal areas. And the CSF and NYU facilitators extracted data for various relevant nutrition indicators and uploaded this data on EQUIST. Some subnational level data were missing and had to be calculated, or there had to be proxies used or missing data rules used in consultation with the Ghana Health Services, the ones who were in charge of the data. Data and shapefiles were uploaded. And scenarios were also tested on EQUIST prior to the workshop. In terms of attendees, there were 30 to 40 Ghana Health Service nutrition experts from each region of Ghana. Most of them had low familiarity with EQUIST, but a high knowledge of Baldneck Analysis and regional nutrition DHIS2 data. So we had, since it was a 5-day workshop, we had an initial training with some of the core facilitators leading this workshop, who were trained during our first week during our capacity building workshop, and who had the knowledge and expertise of nutrition in country, as well as familiarity with EQUIST to help provide this training. And there were 5 Ghana Country Office facilitators who received training from as well from the capacity building workshop. In terms of the exercise conducted during the workshop, the participants who came in on nutrition from each region gave their regional view or their provincial view in terms of the nutrition situation by their region. And there were interventions for Baldneck analysis mapped to relevant indicators. So this is one of the key, I think, sort of key activities that are needed to be done is when you have in step 4 of your Baldneck analysis the determinants that you have per intervention and what causes of Baldnecks there are. They would come in and they would suggest indicators that would best represent each of these determinants per intervention. So they go through intervention by intervention. In this case, they were just focusing on nutrition interventions. So they went through and determined which indicators were the best fit. So on EQUIST, there's already default indicators, but they want to contextualize it to Ghana or to their specific region, however they want to go about their analysis. And based on these determinants and knowledge of the nutritional focal points, scenarios were generated which focused on improving coverage of nutrition interventions with high cost effectiveness, or in other words, low cost, high impact interventions. So this is an example here in terms of looking at steps 4, 5, and 6 on EQUIST and how they developed a table. So they looked at the specific Baldneck determinants, the causes of these specific Baldneck determinants, and this is from Ghana. They're looking just more a little bit generally in terms of what the main causes are for their regions for these specific determinants, and how to overcome these Baldnecks from providing health care or health services through these strategies. In terms of cost, this is the one example of specific costing results that they had attained from EQUIST in terms of their analysis, and this is looking at the costing allocation for the specific strategies that they're proposing to reduce their baldnecks. So the total cost for the one of the interventions that they were looking at was actually quite low for that region. It was only $6,449, and the cost per person they were looking at was less than a cent even. So their impact was lives saved per US dollars, $1 million US dollars was 8,181. So that was a very high impact, cost-effective scenario that they developed in this one specific case. In terms of lessons learned, what we had done is we had sort of provided a live screen which they could provide responses to, and at the end of the workshop we developed basically a poll, or where each participant could provide their inputs through, either through their mobile phones or through their laptops. They could all access and sort of contribute to maybe lessons learned, or what they most enjoyed from the tool, what could be improved for the workshop, and what could be improved on the tool, and just general questions in terms of what they liked the best and what they found the most engaging. So in terms of testimonials received from the nutrition workshop, where the data quality is crucial in developing a workable investment plan, there would be need for timely update and review of the data that goes into EQUIST, and this must therefore be ensured for sustainability. The workshop was excellent. There was enough time that was allocated for practical sessions, and others said that the workshop was good for Ghana Health Service Nutrition, and they were asking if all the data could be made available for all determinants, which was being set up as default on EQUIST, and also if EQUIST can link directly to the DHIS2 data, since most data is available there in DHIS2. So the issue here, I think, that we ran into is that the data that they're using from DHIS2 is very sensitive data, and they didn't want it to directly be shown on EQUIST. They wanted to validate it further. So we set up a space at the back end where the Ghana Health Service can come in and just validate the data before even publishing on EQUIST. So just their team works on it, and once they're satisfied, the workspace administrator can just publish the data and for everyone to access. And it was interesting because even UNICEF country office were surprised seeing the data on EQUIST, and they said, oh, we don't even have access to this data, and we're in country. So this is, you know, a good platform to actually see that data as well, to be able to see these indicators, because we're not given access or shared this data. There were challenges as well during this workshop for nutrition. Despite being recent data comparative to household surveys, routine data from DHIS2 had quality issues, especially with triangulation. And I had mentioned this in previous presentations, where populations from neighboring districts were factored into the denominator of the population of another district where they accessed the health facility. So that caused issues where you had higher coverage rates than were possible. So you had over 100% coverage rates in certain districts for certain immunization interventions. So there needed to be triangulation of the data, and they took this into account moving forward. This is a lesson that they had learned, that with the quality of the data, they needed to improve this. The workshop duration was only 4 days. So some participants also requested that they needed a bit more time. This was set up, actually, the duration of this workshop was set up by Ghana Health Service, because I think they also had, around this time, they had a huge measles rubella 2 campaign going on, so there was some scheduling issues. And there were also, because of internet connectivity. That's one issue that we've been seeing, especially with weaker connections, is that there were some issues with generating scenarios, especially because that's a very connection-heavy process. And then the third and final workshop that we held in Ghana last year happened at the end of October. And it was the Immunization Investment Planning Workshop. And this is what Gavi was, focal points were mainly trying to get input from. So in terms of the preparation for the workshop, CSF and Ghana Health Service worked on uploading immunization DHIS2 data for all 215 districts. And they identified where the key priority districts were that had lower coverage. What had happened is a new workspace was created where we had identified 90 districts which had the lowest levels of coverage and were not meeting the GVAP targets. And so we just created a workspace just for these 90 districts to focus our analysis on these 90 districts. Based on low Penta 3 coverage and measles rubella 2 coverage levels. And they were mostly interested in NMR2 because just the week prior they had a huge measles rubella 2 campaign. So they were setting up district level maps per region to highlight this inequity at the lowest possible level at that time. Who were involved in this immunization workshop were mainly 30 to 40 MOH, the Ministry of Health and Ghana Health Service participants who had low familiarity with EQUIST but high familiarity with immunization data and the situation within their regions and their districts. There were 5 to 6 Ghana Health Service facilitators who received EQUIST training from the Ghana Capacity Building Workshop. So back in that first week, we had some focal points who helped provide training on immunization. There were also several focal points who came from Western and Central African Regional Office of UNICEF, and they had high familiarity with EQUIST and One Health, and they tried to also provide facilitation and trainings on EQUIST. In terms of the data, what we wanted to really highlight here in terms of immunization is that you may have coverage levels subnationally of 80%. So, sorry, this is Upper East region of Ghana. So this is one specific region. And this is an example of the higher level region masking what's going on underneath and why it's important to have a district level analysis. Because you can see here that despite having an average of 80%, only half or less than half of the districts are 80% above the national average, and the rest of the districts are at lower coverage levels. So this is something important to note, why we needed to go down to the district level to unmask this and to see how to reach the GVAP targets. So in terms of the key exercises that were conducted in this workshop, there was a mapping of, just like in a nutrition workshop, there's the mapping of the immunization interventions, so looking at the determinants of each intervention and mapping the indicators to that, and this was done by the workshop participants, and using expert and local knowledge from the participants of key priority low-performing districts to conduct a Baldneck analysis. They identified priority strategies and activities to maximize the cost effectiveness, so maximize deaths averted with the lowest cost. And the UNICEF regional office consultants trained participants on using outputs from EQUIST to generate detailed costs from the One Health tool. So this is where this was applied as well. And they used specific, accurate costing figures to develop cost-effective tables for microplanning, and this would be used in the investment case, and specific strategies and activities through the microplanning would be identified and proposed in the investment case. So just like we saw for nutrition, this is an example of Baldneck analysis, which combines step 4, 5, and 6, which they had taken from EQUIST and presented into a table. And so they show per determinant what their mapping of their suggested indicators are. and these are mainly coming from DHIS2 or their more local sources. And here this is where they had listed their sources from within the country, or if they had a country level survey. So it was very interesting to see where they were drawing this information and how it was impacting the Baldneck analysis, because they're experts at their regional or district level. In terms of cost, this is an example of one specific intervention that we had looked at. They had a lower cost for the specific intervention, but it just shows the allocation of costs that they're looking at. And in terms of deaths averted per $1 million spent, it was just looking at I think around 1,800 or so deaths averted per $1 million spent at a cost of less than 1 cent per capita. And what's interesting here is that immunization interventions in general are very cost effective. They're usually low cost and high impact. So that was something that Gavi also wanted the tool to highlight and to see what results it could bring in that regard. In terms of testimonials from the workshop, we conducted a very similar evaluation of how participants felt the workshop went. We had conducted a survey, a live survey, which they gave their answers again through mobile phones or through their laptops, and the results were displayed live on the screen. So generally they felt the workshop went positive, though it was very short due to scheduling. Ghana Health Service had just had their measles rubella 2 campaign that same week and had to start it late and end the workshop early because they had another series of engagements. So we only had 3 days for this workshop, so it was a very, very quick workshop, and a lot needed to be covered in a very short time. What many felt that it was a well-organized workshop and that it should be introduced to pre-service postgraduate institutions, which is maybe one of the sort of goals that we hope to achieve. 3 days was what one individual said was woefully inadequate, bearing in mind that it's adult learning. And others said, yes, this is true. A single training is not enough. There needs to be refresher trainings more so. And that's why we have this national capacity to go at subnational levels and do capacity building at those levels so that you'd have more sustainable use of the tool. Others said that the workshop should be organized in bits, maybe 3 days at a time for the modules, so that they could understand the topics well and be motivated to use the tool annually, and so to use it more frequently. And others said that we recommend the workshop to any organization that would want to build best investment case to achieve results, particularly for women and children. So there was a huge positive sort of outlook on the scenario analysis, and I think that's the toughest part of using the tool, but once they see what they get at the end of that entire process, it's very rewarding, and it could help in the development of their investment cases. So some challenges that we saw were, as I mentioned, the data triangulation, specifically from this workshop as well. Too little time allocated. It was just 3 days for the workshop due to the measles rubella 2 campaign that they had just launched. And they had requested, okay, we have district level data. Why can't we have sub-district level data now? Because with EQUIST, it goes down at this stage to 7 low levels of disaggregation. So if you have provincial level, you could go down to district level. From district, you could go to sub-district, so on and so forth, up to 7 different layers. We haven't had anyone even get close to the 7th layer yet. So this is something that the tool reports. There would be thousands of sub-districts that you'd be looking at. However, the sub-district shapefiles were not put together by Ghana Health Service yet, and once they do so, they can upload it onto EQUIST, and they can upload the data on EQUIST. And because they do have the data not fully collected at the sub-district level, but they have some of the data there, and they were so keen and interested on seeing that on the tool and conducting an analysis on the tool. So finally, the last thing we did at the end of the workshop was to plan the next steps. in terms of short-term, medium-term, and long-term processes. And this we gave to the participants to give their ideas on what should be done in the next steps. This is something that they should decide how they feel EQUIST should be implemented in country in general and rolled out, and further trainings given. So for the short term, I'll go through this. They said they needed an establishment of a core group of experts for further capacity building. So what they wanted to do is a roll-up training to cover each region and have workshops set in each region of Ghana so that they build local capacity, that they could go around to districts and could provide further trainings or could provide further analyses at the district levels. And they requested for assigning data management rights to regional focal persons as well. So not only at the national level from Ghana Health Service, but also having maybe for each region, regional focal points working on EQUIST to ensure that there is this sustainable uploading of data at the regional level and use of the data for analyses at the regional level. And then they wanted to relook at some of the indicators and getting data from stockout data, especially for commodities in immunization, vaccinations, and they wanted to look at the routine data because they understood, I think that's one thing that EQUIST is good for in terms of data, is to make the country understand that there are gaps in their data, there are issues with the quality of the data, so it really highlights that when you see it visually, so it's something that they wanted to try and address. They wanted to use a means of districts to identify these challenges in terms of measles, rubella, and how to address them. For the medium term, they were thinking of, in terms of 1 or 2 years, looking at refresher trainings and evaluations of processes already occurring with EQUIST. So after they've used EQUIST for analyses, going back and looking what worked, what didn't work, and how to improve moving forward, and to refresh maybe if there's been some turnover, how to increase the sustainability of the tool. For the longer term, so this is a couple years moving forward, they're looking at conducting a pre-service training on the tool, especially to postgraduate students and trainees, maybe having some courses taught on the tool, and finally reviewing and evaluating the trends of coverage in immunization interventions and mortality after these strategies have been implemented. So in order of, they would like to see what's happening in terms of, once these strategies are implemented, what sort of impact these have had, and in terms of what has changed in processes while implementing these strategies at the more national level. So thank you so much. I'll just end the Ghana presentation here of the application of EQUIST. Thank you very much.